Please welcome our panelists to the stage, Puan Nur Zaitun Sanusi, CEO of Specialist Centre, UMSC. Give a round of applause. Welcome once again, Puan Nur Zaitun. She was one of our lovely speakers last year. Next, Dato Amir Firdaus Abdullah, Group Managing Director and Chairman, Aurelius Healthcare. Dato Amir Firdaus was also one of our speakers last year. Welcome once again. Professor Dr. Murtaza Najabat Ali, Chief Executive Officer of Revive Medical Technologies. Our speaker yesterday. Mr. Muhammad Talha, Chief Innovation Officer of Counterintuitive Technologies, KIT KIT. And let's have Ms. Nida Ali, Managing Director of Counterintuitive Technologies. Also, let's give a warm welcome to Dr. Nitya Nantham, Peramal Consultant and Senior Trainer, Impian Halang, Malaysia Senior Berhad, as our moderator for this panel.
Testing. All right, very good evening, everyone. All right, it's a genuine pleasure to be here to moderate this session, Healthcare Workforce Development, Future Ready Workforce Program. And welcome, everyone. All right, so we have two sets of expert panel here. One, Ms. Nur Zaitun Sanusi, CEO of UMSC, and of course, Dato Amir. He's the Group Managing Director of Aurelius Healthcare. And two of them, as we know, they are on the operational side, the administrator of the hospitals. Whereas the other side, we have another group. They are tech innovators, I believe, yeah. Managing Director of the Counterintuitive Technology, Ms. Nida Ali, and the Chief Information Officer, Revive Medical Technologies, Mr. Muhammad Talha. So, yeah. Before we begin, I'd just like to put I would like to set a tone for this moderating session. As we know, our healthcare environment, we are actually standing at the intersection of the rapid technology development, where evolving patient care needs and the healthcare sector is undergoing profound transformation. Whereas on the other spectrum, we have some issues that we need to address as well in terms of the doctor, nurses ratio to the population. At the same time, we have issues of retention and, of course, the distribution disparities among the states in Malaysia. So what we're going to talk and we're going to discuss today, how are we going to bridge these gaps, and are we really ready to take on this, this profound development of the healthcare in terms of the technologies. All right. So with that, I shall begin. Perhaps I'd like to start with Ms. Nur Zaitun. All right. My first question, looking at our current healthcare system worldwide, right? So what will be the best practice in the workforce development that Malaysia, you think that we can adopt in our healthcare professionals to remain competitive and to be future ready? Right. I'll leave it to you.
Okay, thank you, Dr. Niti, and Assalamualaikum, and a very good afternoon, everyone. So, when we talk about the retention strategies of the doctors, medical professionals, I think this is something that, in terms of why they leave Malaysia and the benefits of the other countries providing, I think we all know. It even being covered during the session yesterday. But in terms of I just want to share something that what we are doing, because it's more practical, because it's more on what is the real case on the ground. Okay, at UMSC, because UMSC is a university, is a teaching hospital, but we are on the private side. Back in 1996, University Malaya facing exodus departure of the doctors. So it happened. It even happened before. So what we did in order to retain the talents within the university, this is where UMSC was incorporated. Okay, so but then when you have this so-called private hospital within the university, there should be, you must understand, there should be a policy, a legislation, a law in order, because it will happen that when you too much focus into the private side, you will often neglect the KPI of the university. Because you must understand, our doctors, they are a lecturer at the university. They are working with the public hospital to do the clinical trial research and everything. And they are working with us for their private income. Again, to me, whether it's a public or whether university perspective, it's still about overburden. So it's all linger about the same issue, overburden, overwork, the small numbers in terms of doctors to patient ratio. So it's all about the same thing. Therefore, what am I trying to say? In order to put the effort of this so-called collaboration or cooperation between private and public and private partnership, we must be careful in terms of the the policies to really manage this. Otherwise, you will neglect on the other party KPI or whatever performance, you know. But this system actually has worked very successful for us because we are now entering into our 27 years of establishment. And I believe that we are the only hospital that currently with 100 beds, we are having almost 300 doctors. So in terms of the ratios, we are 3 doctors for 1 bed, and with the income that we have, 1 doctor will generate about 3 million revenue per year. But it's not easy because it takes us 27 years to be of what we are. But the basic principle, I think, is all about the same. You have to manage in terms of the burnout, excessive workload, KPI, all that have to be taken into the consideration.
All right. Thank you, Mr. Zaitun. All right. Let's move on to our perhaps I leave it to Ms. Nida or Mara to answer. Okay. In your experience, okay, we're talking about this retention, right? In terms of the doctor specialists, how do you think the AI, the tech world, going to overcome this ratio to the population?
So, Assalamu alaikum, everyone. The issue that you're talking about, it is there, I think, in majority of the countries in this peninsula. Specifically, if we talk about the experience that we have in Pakistan, it's something similar. But like your minister just said, AI and software is something which can solve a lot of the problems that you just said. The overburden of the doctors, the patient to doctor ratio, the nurse to patient ratio, this can be helpful if we have software and AI working together. For example, you've got a lot of reporting data, lab reports, a lot of that stuff coming in. And what happens is most of the time there are certain elements which are not that very important, and there are elements which are very important, time sensitive. So a doctor needs to sift through everything and then understand who is of priority and who's not of priority. So AI can help you sift through that data faster and with much more accuracy. We're not talking about diagnosis. We're not taking out the doctor out of the equation. But in this aspect, his workload is reduced. People that actually require him will get to have an interaction with him, and the ones that are do not require it, or there are testing which, like there's a lot of testing which is done which isn't very necessary, and it wastes resources and it wastes time. So you can sift out all of that. There are a lot of other elements to which we are implementing AI. We usually call it internationally software as a medical device or software in medical devices. I'm a regulatory specialist. I do compliance with regulations relating to all kinds of medical devices. But post-COVID, what we've seen is that AI and software have become an integral part of the medical device industry and the medical profession as a whole. Because in the pandemic, we saw that doctors and patients could only communicate through this medium. So this has actually evolved to an extent where countries like us, which is why, again, your minister was emphasizing this fact that it is going to save resources, it is going to save time, money, and your doctor's expertise can be enhanced in a way. So I think it's software has a lot of potential in this region.
How about you? Is there any example that you want to address to us? Is there any countries that have been doing this, managed to overcome the shortage of specialist doctors in terms of usage of the tech?
Before the countries, the very major example that I want to quote here is the development of the first computer, actually. That was developed to increase the efficiency of the decryption system, decoding system, and what we today know as the Turing machine. That was actually developed to increase the efficiency of the decoding. So machines, computers, they are there, and today we have advanced enough to increase our efficiencies using the right tools, using the right softwares, up to 200 and 300% more efficient, depending on the same system. So coming back to the question, in US, their healthcare system is very adaptable and very welcoming to the new AI interventions. Even in their day-to-day activities, usually their healthcare system, from the perspective of patient, is categorized into 3 stages: pre-appointment, appointment, and then post-appointment. So they are investing the AI-based automation, in all these 3 stages. In the pre-appointment, their systems are completely automated. The appointments are prioritized according to the patient's criticality, according to the doctor's availability, and many other factors. And then in the appointment, if a doctor is filling up the EMR, their 70% of the time is spent on the EMR, filling up the EMR, and 30% of the time is only dedicated toward the patient. So some of the solutions that even Revive Medical Technology is presented there, and the 100% of the time can be given to the patients. And how that can be done? It can only be done using the AI tools, AI automation. With just one click, AI transcription can record all the session notes, categorize the complete patient-doctor interaction, categorize the important information from that into the examination, treatment plans, and any other, generate recommendations based on that session. And then after the appointment, there has this medical billing stage, medical coding stage that is also automated. So all in all, US, and this is just one example where US is welcoming AI in their patient-doctor interaction.
So may I just ask quick one, how are the doctors are responding to this? Yes, hello. How the doctors are actually receiving this on their end? How's the uptake?
So for the doctor, am I audible?
Yeah, testing. Yeah.
Okay, so for the doctor, in the past, the doctor was, like you mentioned, if he has to type on the computer, meanwhile examine the patient, then again come back to the computer, re-enter their observations, then again direct to the patient. That is also hectic for the doctor. That is also hectic for the doctor as an observer, as a practitioner. And then after that, even for the administration, it is hectic because they have to go through each medical record again just to infer the applicable medical codes, applicable CPT codes and E&M level classifications for the proper insurance claim, so they don't underclaim or they don't overclaim. So that's it.
All right, thank you. Right. Next, I'd like to address some questions to Dato. Dato, I think when we mention about workforce development, I think we can't forget about the nurses, right? So one data saying that in by year 2030, we're going to have roughly a shortage of about 100,000 nurses in our country, right? So in your opinion, in terms of the private healthcare, how healthcare organization that can actually address, especially the private sector, bridging the gap? Because as I mentioned, at one end, the healthcare needs it's evolving rapidly. At the other end, we are in a shortage of healthcare workforce. So how we can address in terms of the development in this country?
Thank you, and assalamu alaikum. Very good afternoon to everyone. It's a pleasure for me to actually be here again, invited at the Asia events. One of the things that perhaps will be important for me to share first to Dr. Niti is with regards to my own experience in sort of managing healthcare. So most in the room might know me as managing Gleneagles and Pantai hospitals in the past, and then having gone off to Abu Dhabi on an international stint and then coming back again. And you're quite right. I think the question is all with regards to what are we doing with workforce? And it's actually not really a shortage only in the nursing side, but pretty much on the doctor's end as well. And the amount of specialists that we actually are producing at the moment. I'd like to just go back as a rejoinder to Puan's earlier share with regards to where has created a very different ecosystem. And what we have done in private healthcare, unfortunately, at least in Malaysia, is that we then go and make it as attractive as possible, and we take these doctors over, and they do reasonably well as well, from a financial perspective. And I think that is one of the guiding principles that's still going to be there. The fact that can you, in fact, be that impetus creator to ensure that there is, sort of a quality in life, as well as the requirement around payments. And unfortunately, whether we like to state, and of course, it's a little bit of an antithesis, right? Because you'd say that healthcare should be more altruistic, it should be all about providing care, and it needs to come from the heart. And anyone who's gone for an interview as such in a hospital will definitely say that I'm here to serve, I've always wanted to take care of patients and whatnot. But there's a reality as well. And I think the shifting forces in what's happening with the younger workforce, I've been doing this now for 40 years. I have seen that the change is there. And I think organizations would have to change as well if we're going to get across this to actually understand. And it's no more about the Gen Zs and millennials. It's actually completely understanding what is important for them. And one thing I think that most organizations, and this is again reflecting upon what we were doing in Dubai or what we were doing across the continent, it was all about how do we in fact ensure that we are keeping ourselves connected to the people that are most important to us. So generally, as my team knows, and I'm glad to have some of the Aurelius Healthcare senior management here today, I mean, it's always been about people, services, quality. And that might be my 2 minutes of self-promotion to a certain extent. But it's actually about people. And if you are speaking about that at your boardrooms and you are discussing customer care at your boardrooms, this is where I think the nearest propensity for you to get the most out of that connective tissue with your staff is going to be established. What we need to do, obviously, and we had this in Malaysia. So when I was back in Gleneagles in the early 2005, 2006, we had a shortage then as well. There was a change that was done by Ministry of Health and Nursing Board, and it was very clear that colleges had to produce more. And they did that, albeit at perhaps there was a discount on the quality of individuals that we had. I hope it's all right. We have doctors in the room, so I guess, I'm sure. And this is where I thought it'd be important. If we are going to speak about people in the way that we want to have longevity, we want to have that connective tissue in place, it's going to be very important for us to actually think about what keeps things attractive. And if it doesn't, I think we need to actually look at that from a perspective of basically a business owner, a perspective of wanting to produce great healthcare and consistency in the team. Because attrition has got its own costs associated with it at the same time. So I would think those would be things that we should be putting up and forward. And also, and I don't mind really sharing this, is something that I think is important for nursing development. What we tend to do, and I've shared this very many years over the years, and some of my team always says, you're giving away our secrets. But it's actually about understanding that when you have a good nurse manager, what people like me do, CEOs in hospitals, we promote them as managers. But they actually don't do very well as managers because it's not their forte. They were good clinically, but we took them out of their space and we put them on that road of, we're going to develop you as a manager. And they really don't do well at it. So what we tend to do is we try to look at them from a perspective of clinical leadership, ensuring that you can step them up in that pathway. And one, of course, the more traditional way, ensuring that nurses are there and we can take them through the management road of development as well. And finally, through that particular perspective, ensuring that they're able to become educators as well. And I think with these three streams being included in most hospitals, you are then able to have the best of that particular individual being represented in the way that they will feel happy, they'll feel that they are developing, and we've actually listened to what their core, sort of attractiveness is for nursing. I think that's going to be quite important. So for us to really know that those are the drivers and those are the things that are going to be important ultimately. And of course, you can't underlie the fact that there's a lot of technology and other things that's going to be enablers for them and putting that up front as well.
All right. Thank you, Dato. All right. Puan, in your organization, okay, talking about the nurses, right? So do you have any shortage? Shortage, and then especially the post-COVID, is there any scenarios that you'd like to share, and how did you actually ensure adequate nursing support that you had in organization?
Okay, in terms of the nursing, I think what is actually happened in terms, not only before or after COVID, I think even now we are having shortages, and Dato', you would agree that they are pitching each other at the corridor, So because when we conduct an interview, so we'll find that the candidates are from Sunway, are from Aurelius, So this happened in the industry. But I just want to bring something out of for the discussion for us to brainstorm. But when is it going to end in terms of the pitching of nurses? It's just like pitching of doctors. Because what happened at UMSC, we don't allow our doctors to work outside, vice versa. Or, even though it's hard to implement, but we put in their contract, if there is any, you need to pay us the bill of whatever amount. And I think something that we need to do for industry, for the nurses, Dato' and the panel, otherwise it will be no end. Because today, because I am Sunway, I can pay you more. But tomorrow, whoever that come in the industry, I pay you more. But what is it going to end? What will happen to the industry, to the healthcare in the country? But this is something that we need to sit together, perhaps with the MNB, Lembaga Jururawat Malaysia, something that we can do in order to curb this transferring here and there. Because by the end of the day, it doesn't look good for our industry. Because the fact that they are jumping, not because of salary of that much, it's just like few hundreds, But this is something that I don't find it's healthy for our country. But again, in terms of to echo with what Dato' has mentioned just now, we did a lot of things for our nurses because pay, career progression, but we must remember by end of the day, they are just human. They just want to have a good life. They work stretching hours. They are leaving their family because they could be somewhere from Kelantan or whatever, they're working in KL. So again, by end of the day, what is it for me? So this is something at our hospital, we are doing it. Every little thing, but it gives a big impact. Like nursery, like medical insurance, provide them accommodations. And recently we just approved the pilgrimage for all faith.
Oh, okay.
So again, this is something that you do because it's about you. You can give whatever, but again, I just want to have a work-life balance. it works, but I am afraid on the part of pitching of these nurses will continue.
All right. So for the panels from the tech worlds, so how are you actually looking into this aspect? So have you have any experience? How are you actually, managed to resolve any issues in terms of nursing in other parts of the world?
Actually, the thing is, the two elements that our colleagues just mentioned, they are very important. Number one, being overworked, and number two, the facilitation of any kind of person. At the end of the day, we are all humans. So if we are being overworked or overburdened and not being supported as such, obviously we are going to look into other venues and go about. But what is happening in Europe and in the US, as far as we've been working with both the areas, they are facilitating the nursing staff with tools, either they are AI tools or they're software tools, to make their job and their life much more easier. And this allows that burden of work to come a little lesser. So if they are facilitated, in a certain hospital like yours, if they're facilitated, maybe they won't like to transfer, even if it's for a little bit of money, but they're being facilitated, they've got this luxury of support with them, that might become an attractive figure for them to stay in. So this is what usually is being done, because in the NHS in the UK, what happened was this deterioration in the quality of life specifically for the nursing staff, because for physicians that's a different ball game altogether, but for the nursing staff the quality of life was deteriorating. So they started elevating their incentive, they started facilitating them with these tools that are coming up. So now I think the nursing staff in the UK is one of the most facilitated staff in the European area. The British NHS system has elevated that. I've been working with them for now 5.5 years, and MHRA and NHS has supported their nursing staff, given them that due importance that was actually previously only given to physicians and doctors. So this is something where I think we can focus on even here in Malaysia and maybe curb this problem that you're already having.
Okay, so let's look into the distribution disparities that we have in our country. What I mean by disparities is, as you can see, some states in the country, they have the doctors, nurses, population ratio, which is not similar. For example, one figure says here, in Klang Valley, we have a ratio of 4.1 to 1,000 population, whereas in Sabah Sarawak, we only have 1 to 1,000, right? So, in your opinion, we have been talking this issue for many years, all right, the disparities of the doctors and nurses across the states in Malaysia. And now with the emerging of the technologies, on the other hand, so are we really ready for this? So that's the question.
Perhaps if the question is about disparities, yeah, I think that goes with really the economic side of things. And Puan was speaking a little bit earlier about this pinching that's actually going on at the moment. How do we make it attractive? So when we started, or in my earlier past, when I started Gleneagles Kota Kinabalu in Sabah, we had decided that we were going to be the best payers. So from that particular perspective, we were able to, in fact, get the nurses that we wanted. But there's always going to be a disservice that occurs to the other competitors that are there. I mean, the same thing in Aurelius Negeri Sembilan at the moment in this hospital that we've built up. We don't lose many people because we pay well. Bonuses, we share profits quite a lot with the staff, because now it's no more supporting Khazanah National and Mitsui, but it's more about me and my shareholders, and we're quite happy taking less for ourselves and more for the staff. So we do have 6 months bonus and things like that. I guess if you wanted to equate how it would be, in an open market, if we wanted to create that chasm where you can still have, pinching that actually doesn't occur, we all need to then agree that this is how much nurses should be paid, and we value them in that right way. And I think that's part of the problem at the moment in the country, at least, that very few people want to enter nursing because, firstly, it's one that is going to be less glamorous. There's no glamour around it. It's just not sexy enough, exactly. And the fact that, what is the career progression in that? So we tend to have, when we have our inductions, we tell them, look, just next to you, for instance, Joanna, who is my CEO in that hospital, she was a nurse formerly. And there's other people that have done so well just from nursing. But seeing that actually occurring, I think is going to be quite important. But the disparity, I think, will come where you've got the economic availability to be able to attract this group of people, and that actually starts to reduce the individual. And the part that I think is also conflicting our data is the public health system. So that, I think, skews somewhat that figure, because it's not on value base, but it's on the ability for the government to continue a socially funded system. And that too has got its limitations. In Sabah, for instance, when we opened Gleneagles Kota Kinabalu, I had to go and apologize to DG, Datuk Sri Norisham at that point, because I said, look, we might have to take at least about 5 to 6 very good consultants and bring them in from Likas and Queen 2 and start up this hospital. But we'll allow them to go back, if they had to deal with the patients. But that is the problems that are there, because there's just not enough of services to start with, I think, even on the public end. So it's an ongoing thing. And just one last thing, perhaps, on the earlier part of your question, Dr. Niti, where you asked about how do we ensure that we have enough nurses moving forward. The problem that we had in the past, which I am quite sure we're going to have to repeat, we will be repeating it because we are not learning from history very many times, at least in the things and decisions that we've made in the past, when there was a need to actually have more and more colleges. We had so many colleges open up in such a quick spate. And then what happened? The nurses couldn't find jobs at all. I remember, oversupply. And we had basically nurses, going and joining banks as, selling credit cards and all sorts of things, because there's just not enough of jobs available at that time. And I do suspect that now we're having this particular crunch, that's going to happen again. And the same thing happened with doctors as well. And the entire raison d'etre, as one would say, the reason for which nursing board, MMC, Malaysian Medical Council, all of these, I think, need to establish those particular standards for all these schools that are coming out, and the amount of schools that they allow to be licensed. I think it's going to be very important that too is curtailed and maintained in the way that is a little bit closer to where the demand is. Otherwise, this is going to repeat itself again in a cyclical manner.
Yeah, sure.
I just want to add, because the recent study that we do in terms of the number of beds, we have about 4,000 plus beds that we need for Klang Valley, not Klang Valley, for the entire nationwide. So whenever we embark into these nursing colleges in producing more nurses, we've got to be careful, because the market will be saturated. So what when you implement encouraging students to take courses on nurses, you've got to be careful, because by then, when the beds are all ready, what is it will happen to them? And we should learn from the past experience.
All right. So last question to Mr. Talha. Okay. In your experience, have you ever, how does AI actually manage to resolve any healthcare workforce maldistribution? Is there any particular scenario or situation that you have actually encountered in the European countries or the Middle East that you managed to overcome this situation?
Yeah. So Ms. Nida gave here a very good example of sorting the lab reports and prioritizing that. But yeah, AI can be helpful in almost every domain as a tool, and especially if we talk about this distribution disparity. AI can assist in the load sharing phase, and by load sharing I mean the level of AI, the level of your of the complexity of your models, the level of the technology that you have, that will eventually decide the intensity of load that the technology can share in your organization. If you invest more in the technological side, you have more computational resources, you can make a trade-off between the computational resources and the human resources then. If you have more human resources and less computational resources, then obviously there is again a limitation on the computational side as well. But computational resource is that might be a bit controversial. But computational resources, I think, easier to get and easy to manage compared to the HR. And with a very less amount and with a very less effort, you can manage the computational resources. And by the computational resource, I mean the artificial intelligence, I mean the traditional machine learning models, I mean the traditional algorithms that are in place, that are in market, and that can be used to automate, and that can be used to share the load on the existing administrations, existing overloaded staff in the hospitals.
All right. So yeah, so we have last 3 minutes. Perhaps I'd like to open to the floor. Is there any questions that we want to discuss or further address by our expert panelists here? So feel free to raise your hand and please introduce yourself. Yeah, 1 minute. I'll pass the microphone.
Thank you. I'm Ahmed Mazali. I'm the Business Development Manager. I wanted to ask a question related to AI, because as AI is taking over a lot of spaces, it's almost in every technology now. Similarly, with advancements of AI, there are a lot of concerns which are coming up related to AI as well. So when we talk about AI in healthcare, AI in medicine, what are the possible concerns that we might be vigilant for, and what are the possible areas in which we can try to avoid the harms of AI in healthcare and medicine?
Yeah. So the very first threat that comes in here is AI is a tool, not an entity. If you treat it as an entity, you'll be stuck and you'll face those consequences that you just mentioned. So if you treat AI as a tool, you'll have to evaluate their efficiencies in terms of the KPIs, like you mentioned. Yeah.
Decision making.
Yeah, exactly. It should be in the supportive mode, in the system mode.
You can't
And
take the human factor out of healthcare. Healthcare it has to be human driven. Right? Actually, one thing that you just mentioned, the statistical portion, for that, I think AI can be of use. If you have AI do all the statistical analysis of what the demand is and what the resource should be, I think this is where we've not applied AI to anywhere. And if Malaysia is where you've already experienced that there's been a lot of influx of people with a certain skill set, but they don't have the job opportunities for that, you can curb that if you apply AI and then not rely on what government-based decisions that you already have. Maybe AI can help in that.
Absolutely.
in terms of the concerns, you should be really your data that your AI is going to be trained on, that should be as reliable as the model is going to be. So eventually it really depends on the data. There is a problem that all the GPT users might have faced, that if you keep a conversation longer than usual in a GPT, a thread that you say, it stucks in a loop. It starts generating answers in the pretty same manner, and regardless of the input that you provide, regardless of the prompts that you provide anymore, and it stucks in that loop. And now that they have added the memory retention feature in it, you can't really create a new chat and expect GPT to generate some useful answers now. So what you have to do is you have to erase their memory, you have to delete all their chats in order to generate the new recommendations. Why this is happening, why it gets stuck, it could be for several reasons, but one of them is that GPT, when came into the market, it was the, actually I think AI became the buzzword after the launch of the GPT. And many thanks to OpenAI. And right after that, everything you see on social media, everything you see on the digital platforms, that was generated by the GPT. Still now, till today. And sorry, even the topic that we had there, that from policy to practice, that is also one of the templates that GPT uses to generate these kind of titles. So everything when generated by GPT is on the social media. What will GPT be training on in the next versions? On itself? In itself?
There's also black boxing. There's a term known as black boxing in decision making in the healthcare, where AI actually blinds the physician from the process that it has gone through to decide, give an interpretation. So that element we're still left to overcome. The black boxing effect, we're still trying to overcome that in healthcare, AI healthcare softwares. So that there are still aspects that are in the gray areas as such.
I'd like to,
Yeah, Dato',
if
please.
it's possible, just to add some thoughts there. I guess one of the major things that comes to my mind, I think quite importantly, is how you apply it. But quite importantly is also going to be medical ethics and the information that you actually tell a patient about how you're actually going ahead and providing that particular provision of care that needs to be consented. And the patient needs to understand what the loopholes are with this. The one part I feel that we have always been a little bit behind, at least for healthcare, is that if you look at the financial side, banks and other things, I mean, they've been using computers far better than what we've been doing in healthcare. And for us, when we think about the paperless, it's been going on for ages. And it's never really come to a point where you're integrating all the clinical information of the patient, whether it's ECGs and everything else, and then using the full computation to ensure that you can get to a point that you can actually apply this. So in my view, I think one of the things that are missing is the blueprint that some people say needs to be legislative, needs to be almost law, and that needs to be then followed. I think that's another huge cross that we have to get through. And then there's also the other part about generative AI as well, where now through machine learning, you're actually getting the decisions that are made in the future based on the algorithms of learning today. And that's even a lot more scary because that's when the doctors have to have a complete understanding of how this works before they can allow that to go forward. And we looked at robotic surgery. I mean, I'm sure if there are payers in the room, I know that PM Care is here with the great doctors from PM Care. And you'd understand that this is something that, what's the cost of a benefit analysis for something like that? And that too, I think, will be discussed heavily before a person like myself, who's investing directly into private healthcare, thinks about how this will be an ROI to a certain extent. So it's complex, but yet easy. But I think getting that framework in place is going to be ultimately most important and paramount.
Regarding the ethical side, in some countries, especially US, UK, and even in Europe, there are regulations to keep patient data, patient notes, their reports, results secure and safe. Even if you are exposing them to AI, there are certain protocols that need to be in place in those scenarios. In Malaysia, yesterday there was a talk that mentioned some cybersecurity measures that could be taken in the MDA, some policies that need to be added in the MDA regarding the integration of software and regarding the software as a medical device. So I think introducing that kind of regulations in MDA may open secure pathways to the Malaysian hospitals and clinical systems to welcome the technology that is available in the market, because the world is using it, and if we are not using it today, we are already late. So, yeah.
All right. Thank you, everyone. All right, I think with that, we are running out of time. So I would like to thank all our expert panels here for contributing to their mind. All right, with that, I would like to have a round of applause for all our expert panel. All right, so yeah.
Before that, hello? Before that, could we get a quick group photo? A huge thank you to our moderator, Dr. Nida Ali, and all panelists for this session. Your expertise has added great value to our event. Thank you very much.